And obviously, all the questions that patient ask you, and you
I
sometimes
can't hear you now.
what? You don't hear me? Hello?
What the heck?
You don't hear me? Hello?
No.
1, 2, 3. What?
I'd like to think that he's not just muted.
No, he's not muted, but
We're not.
I'm not muted, no? You don't hear me?
what the heck? Try talking now.
1, 2, 3. Do you hear me?
Nothing. No.
Are you just pulling my leg?
Do we need to take a video to prove it? Like,
I
I feel like
think
he doesn't
thinks,
believe.
He thinks we're
because-
pranking
I
him.
know. That's why I'm taking a video.
Because
Ah.
because on YouTube,
We're not pranking you. I have no idea what you're saying.
And you're not muted.
Don't even. And we're turning up the volume.
it is yours. Because on YouTube, I hear it.
Try talking now.
1, 2, 3.
Okay,
1, 2,
We're good. We're good.
okay. Okay.
Good thing I'm so smart.
Yes, you are. Yes, you are.
Oh, yes, you are.
Smart girl. Who's the smart girl? Yes, you are. Yes, you are.
No, but we can be.
What did you
Okay.
say? Okay, we are online. Go. Let's go ahead.
Hi, guys. Thank you for watching. This is Essence of Medicine. Today, we're going to be talking about post-op expectations. I'm Amanda Armagast.
I'm Melissa Hopper.
And I'm Dr. Abbasi for Essence. Now, post-operative expectation. The origin of this podcast comes from Alyssa coming to me and telling that what are the most common question patients ask us. And until now, we thought we do a very good job of conveying the information, what to expect and what not to expect after the surgery. But I think it's time to have an update. As a matter of fact, if you want to hold that brochure up, we have made a book about managing expectation. What that means is practically a surgery is an injury to you. Any surgery is. And hence, you have to recover from that. In that process, certain things are absolutely expected, and certain things are warning signs of some kind. It is rare that there are any warning signs, and I can just tell you that probably, if not 9 out of 10 times, maybe even more, maybe even 98 times out of 100, things are just the way they are supposed to be. But if you don't know that, they can be concerning. So, Amanda, what do you have a procedure coming up soon?
Yep.
Have you been educated about what to expect after the surgery or after the procedure yet?
I'm not throwing my place under the bus. I've not been educated for after the procedure, but this is a very different procedure than what you're having. I'm not having a surgery. I'm having something that is minimally invasive, I think, is what they would consider that. It's not a surgery where afterwards I have to be like slow. I don't have I only have some eating restrictions. I'm supposed to eat like kind of low fiber, a little bit light.
Okay, but how
I
did they?
I guess I've been educated in that sense that I don't have anything that I have to be worried about, and that I have my diet to stick to.
And sometimes that's all what it is to it.
Yeah, and that's probably all this is.
But now I want to ask Alyssa, you see a lot of our patients. Tell me, what are the most of the question and concern you hear after the surgery? What are the most concerned patients bring to you? You answer a lot of calls. Tell us.
Yeah. Well, the most commonly asked question I get before the surgery happens is, how long am I going to be laid up? Without a doubt, that's the number one. They think that they're going to be laying in bed pretty much nonstop, and they want to know for how long, which we know at this point is not entirely accurate.
Do you want to tell us a statistic? Obviously, for individual patient, we don't know how long they're going to be laid up, but we have a statistic. We have a good statistic based on thousands of patients, 10 years of results and data. We know if you have a spine surgery, usually people stay, vast majority of the patients are able to ambulate same day within hours. As a matter of fact, more than 96% of our patients are discharged within 24 hours. That's why we can do many of these complex surgeries in our surgery center, because if you cannot ambulate, you cannot go home. But more importantly, we know that the recovery is twice or three times faster than open traditional surgery. But as well, this is not instantaneous recovery.
Correct.
One of the things that I'm asked always, when can I go back to work? Well, what would you answer? How would you answer that, Alyssa?
Well, that is a loaded question. A lot of it depends on, well, what do you do for work? You know,
Exactly.
how invasive is it? How much, you know, of those
Mhm.
restrictions, we do a lot of avoid bending, lifting, twisting with some weight restrictions and such. I'm a big, if you're on narcotics and pain management, obviously that's a big no-go for work.
For many works, yes, absolutely.
So it is a 110% based off of the individual patient.
But it is, but what I said to my patient exactly the same thing, but I add to that it is reasonable for vast majority of the basic daily activity. It's reasonable to believe that within 2 to 4 weeks you are back to the basic daily activity. Why is it important? Because open surgery that happens in 3-4 months, not in 3-4 weeks. So we are much faster to recover from the surgery, but still it takes time to do that. Now, what kind of work they do truly dictates when they can go back to work. If you do desk work, some of our patients go back to work within a week or two. If you do roofing and construction work, you have to wait a little longer. Though I have been surprised that many of our farmers, which are very hardworking people, within weeks they go back to farming. Not that I recommend that.
You know the joke about farmers.
So I have many jokes, but tell me yours.
I'm talking about the joke, like when the nurse gets a call and they're like, the farmer's on the way, and everyone's like,
is he coming voluntarily? Is he coming by himself voluntarily? And then if the answer is yes, call the
I was to say more than
Yeah.
likely, probably not.
yeah, call in everyone.
Unless it's a rainy day. No offense, I understand.
So but more or less it is about the kind of work they do, and they recover much faster, but it's not instantaneously. Now, so continue with the question that you are asked. Let's dissect them together.
Yeah, okay. A lot of the questions I get, another one is tied on to that. It comes to, we require physical therapy before, and they ask a lot of questions on how am I supposed to recover after surgery? When can I start this physical therapy? When am I going to get this range of motion back? All of those typical, not even necessarily pain questions, more so like my life-related questions.
Let's talk about the physical therapy.
Yeah, let's do it.
Now, physical therapy is an integral part of what we do. Especially because the way we do the surgery, contrary to open traditional surgery, we do not fillet the muscle. We do not destroy them. Once in a traditional surgery, you cut the muscle, you cut actually the part that the muscle attached to. We call that laminectomy or facetectomy. That muscle has nothing to attach to. Those muscles all die and wither away, and there is nothing you can do with that. They're scars. So, but in our surgery, we don't do that. So for us, it's a huge value for the patient to build up more muscle before the surgery, because after the surgery, those muscles help the patient as a brace, as a perfusion for the bone, and then you can train them as well. So all our patients get physical therapy before the surgery, and certainly as well after the surgery. Now, obviously, there is something come with any kind of surgery or injury, period. What happens if you hit your arm, Amanda? You're walking around, you hit your arm. What happens? It swells up, it gets bruised, it swells up, right?
Yeah.
And that is a natural process where your cells of your own body go there to repair the damage. And then when does the swelling goes away? When does the bruise goes away?
It kind of depends on how hard I hit myself. Usually I'm not swelling.
How often do you hit yourself?
Oh,
A lot.
A lot. If you look at my legs, I'm bruised. I would say the last a week. Yeah, a week about.
Yeah. And that is, you see, you have a common sense of understanding how our body heals. Because that's one of the things we tell to the patient is that for the first, right after the surgery, tissue start healing. That healing requires swelling. That swelling is worse around the day 3 and 4, and then start going down. And that is as well the same time around that the bruise become less and less visible and they go away. Okay? That is a natural healing process that I cannot overemphasize how important is this knowledge we just talked about that you know from your chicken care, all the bruises you get from your chicken care, how important that knowledge is. It's true. Most of the time you get bruised when you're taking care of your chicken, isn't it?
I
Just
wouldn't,
exposing me like that.
I wouldn't blame my chickens per se.
I have
Now
bad
let's start,
control of
Yeah,
it.
same.
let's start with the neck surgery, ACDF. This is a common surgery we perform.
Oh.
We do the surgery. We just talked about that for 3 days. Tissue starts swelling.
Mhm.
And what happens then? What at the third day they call you, they say, tell you, what would they tell you on the third day? Or second day sometimes even.
They typically see a lot of the inflammatory based symptoms, meaning, okay, I'm starting to get, pressure over my neck, sore throat, maybe difficulty swallowing, which typically
Yep.
can cause a little bit of shortness of breath or some anxiety based
They can
circles
aggravate each other. They can aggravate each other. See,
when they
if they
do.
don't know this is a natural part of healing, all of a sudden it get tight in the neck. Swallowing get harder, pain get worse. All of that related. Now, you don't know that's going to happen. You are going to get more anxious. And when you get anxious, you perceive the pain more at higher level than it really is. And
Mhm.
they feed to each other. I just had in a different location, I did a neck surgery, a very young, anxious patient. And that patient had to go to the ER because exactly what we discussed about problem with the swallowing and some of the pain is getting worse. And you combine that with anxiety, high anxiety, you combine that with the ER doctor who has a high anxiety, they were about to intubate the patient for something that's a routine postoperative care. Yeah, it just happened. But then we intervened, we said, this is normal, let's get a CAT scan. We didn't even need to get a CAT scan because we know everything is swollen there. We know there is air inside because when you do surgery, air from outside comes in and so on. So, but just knowing that what you just described, Amanda, it covers a lots of postoperative expectation that swelling is a natural part of healing.
Yeah.
Depending on where the swelling is, some of the symptoms get worse. If it's in the neck, swallowing gets worse. You may feel tight. Breathing is important. If you have the hard feeling that it's hard to breathe, you always have to go to the ER. So coming back to that, problem with breathing is not a natural part of postoperative swelling in the neck. Problem with swallowing is a natural. Pain is a natural part of process. Let's talk about the same part, swelling in the lower back. We were talking about physical therapy and I hijacked it and I talked about swelling. Why? Why did I hijack it and talked about when do we after the surgery start physical therapy?
Well, I typically give them about a month. They come in after their 1 month and then we say, okay, let's start the physical therapy. Some patients started it sooner. Give them a week.
We show them activities before the surgery in the physical therapy. If they're in the hospital, we do few sessions of physical therapy in the hospital. We teach them what to do, what not to do, and then we wait 2 to 4 weeks until swelling is down so they can perform better, they can keep up. So it's not everything is not painful because otherwise they would go to physical therapy and everything they do is painful. They build walls and anxiety against that and they don't do that, which is a good thing for them. So you see our protocol consider that. That's why we don't send them right away to physical therapy. We wait 2 to 4 weeks, the first postoperative visit, then we send them to physical therapy. Now, swelling in the lower back has other effect as well. than swelling in the neck. Now, and another important, very important factor is in our surgery, we don't fillet the muscles. We don't create a big cavity. Because if you create a big cavity, things can expand to easier, right? Like you imagine you have a huge, obviously, there's lots of damage, and the risk of infection is 15 times higher. But in our surgery, we don't have a big opening, big cavity. So things that swells are more likely to push on adjacent structures. So what we tell to the patient, obviously in our surgery, we push the nerve to the side. That by itself is 10 to 15% risk of nerve irritation. But even if they don't have it, they may get it after 3-4 days. Why? Because tissue starts swelling. And if there is no huge cavity there, it's that pressure has to go somewhere. It goes to the adjacent structure. So they call us, typically they call us Sunday afternoon when they run out of medication, that it's something is not right. I have pain. I didn't have it the day before and so on. And 9 out of 10 times we listen to them, we rule out signs of infection. Now, infection is never expected. If you have an infection, you have to always go to emergency room or ER or somewhere else. But the pain getting worse is expected. Swelling getting worse and pushing on the nerve, so the numbness getting worse is expected. Sometimes even getting a little weaker in that, like when you're swelling up, it is expected. But infection is not expected. But if they call you 2 days after the surgery, and how concerned are you concerned about the postoperative infection, Alyssa?
Not very concerned at that point.
But not very, exactly.
Right. How can a patient tell the difference between just swelling and like an oncoming infection?
Alyssa, we asked them questions to identify
and
that.
this is why she needed to be involved in our wound or our infection podcast I think we had when you were gone, and we talked about the signs of infection, kind of when to expect it. Well, we know infection takes a while to develop, meaning you don't typically see the symptoms that soon. You see this, what do we say, the rhubarb? What are those 4 fancy Latin words?
Yeah,
well, let's keep it patient. How can a patient
exactly.
No.
If you question, you call us. We help you with that. So as a patient, you don't need to know all of that.
Yeah.
But swelling itself is not sign of infection. But if you have fever, chill, and the purulent material leaking out of your incision, that is a good sign of infection. But in doubt, that's why you call us. Now, one of the major part of the infection is that it's not only swollen, it's painful to touch. And as well, sometimes you can see it's not only painful when you had the surgery, it's painful way around it. But again, we don't expect lay people to understand that. So what we do, we ask questions, and they should call us for that. That is the expectation. If you think you are concerned about the infection, don't diagnose it. Call us. We help you. And if there's any sign of infection, they have to go to a local emergency room, which happens extremely rarely in our cases. As a matter of fact, in our older procedure, after 1,600 cases, we had only 3 infections, and none of those 3 infections required the surgery. Whereas after regular surgery, you have 3 to 5% risk of infection. So our risk of infection is almost like 1/20th of open surgery. But we educate them that, these are to look for, and this is when you should call us. You should be less concerned. But either way, infection does not happen 2 days after surgery. It needs time to develop. That usually about a week or 2 after the surgery, that the surgical infection becomes clinical, important. Okay? But still, if there's any sign, you should call us. That is one of patients' expectation, to call us if there is any sign that may be an infection.
Right, sure.
I'm
Now,
a big believer of that too. I'd rather any not worry about it. I
Yeah.
get a lot of patients that say they didn't want to bug us. And then
yeah,
they sat there worrying for 3 weeks until their next appointment.
Bug
And it just
them.
breaks my heart. And I go, what do you think I'm paid for?
Right.
You know, like to take care of you, not to let you worry for 3.5 weeks. And they always smile and, oh, I appreciate
Yeah.
that. And then, they never
Well-
reach back, but they know that they can.
Yeah.
so if you go to our patient education sheets,
Mhm.
the big team there, and for everybody who's listening to that, I have another podcast or YouTube content. It's called A Natural History of Spine. I think everybody with or without spine problem should listen to that because it tells us what our spine is, how does it age, and what can we expect from the spine, and what we realistically cannot expect from the spine.
You'll learn a
So-
lot actually from that video. There's a lot of information packed in there. It's like 40 minutes, but
Yeah, I think it helps you to understand. And one of the major thing I want my patient take from that video, the natural history of spine, is start having a lots of hobbies. Because life, if you're lucky, going to make you get old, and then you're going to lose your ability to perform many of the hobbies that you live for. But if you have a lot of hobbies, then you can keep going and have fun. That's what is life about, right? And I give you two examples, real examples of real patient. I have this patient. He's 89 years old, and he is a year after the surgery. I'm just going to the room to just look at him and see him for the post-operative follow-up. We do multiple. One is 1 year, and he's fuming. He's angry with me. And I'm looking at the films. First, I thought something bad is happening, and I'm looking at the films. Everything is perfect. Bone is growing. Everything is in a good position. And I try to dissect that with the patient. I say, let's talk about the pain. I go to my note, and many patients don't remember their pain. But I go to my note. He has 9 and 10 out of 10 back pain. He has 8 out of 10 leg pain. He has radiculopathy. He has weakness. And we go step by step. The back pain is now 3 and 4. The leg pain is gone. He can now walk a mile. He couldn't walk like even 1/8 of a block.
Mhm.
But his pain gets worse with certain activity. Is that expected a year after the surgery? Depending on the activity. His pain gets worse because he lives for motorcycling.
Mm.
He goes every year with his bride, his wife, who's 84 years old, from North Dakota to Sturgis, South Dakota. And he tried to do that, and his pain got much worse, and he couldn't do that. And he's angry with me because of that.
so why does riding activities like riding a motorcycle hurt after your surgery?
Alyssa, go ahead. You take on that.
Again, I've rode on several motorcycles. I do not drive them myself. They are very, very jerky, very bouncy,
Okay.
a lot of pressure on your back. Typically, when I describe to my patients, our discs are supposed to be our shock absorbers. When we do certain activities that cause extra stress on it, we typically get symptoms from it. Patients that come in and we fuse them or we give them hardware, essentially trying to stabilize it. Typically, activities that would have caused those symptoms prior would also exacerbate them.
Sure.
Even with the fusion. Typically, again, that's how I've seen it.
Now, let me give you actually a natural history of spine right now. Human body is made to drive 60 miles an hour?
No.
60 miles an hour. There are
No.
some animals are made to move that fast.
Mhm.
You should go look at their body, then look at human body, which is miserable comparing to them. Now we take a body that is not supposed to drive that way, or or walk that way, or run that way, or move that way. We put it in a situation that it's doing that and more. That is a 90-year-old body almost. Okay? The shock absorber are gone. There's nothing there, with or without surgery. But
Tires.
the idea here is he's angry with me because he was expecting to get that. It is
Mhm.
not his fault. It is my fault. I failed to make him understand that my surgery cannot restore the shock absorber and make his body a 30-year-old or 40-year-old spine.
Mhm.
So,
That's-
and practically, that is a big part that we should let our patient know.
Mhm.
We can make them the best they can be for that age group. We cannot make them, no, they're in that natural history of spine. I draw a line and I say, this is somewhere you should expect to be after the surgery to be better than for age group. Like I call that the Benjamin Button curve, or the curve of eternal dissatisfaction, because it is not in our domain to make people younger.
Mhm.
It is in the realm of science fiction, fantasy, that you can get a surgery, then all of a sudden you're back to your 20s. Now,
Mhm.
many of our patients, they tell us they feel like 20 years younger because they felt 20 years older than what they were before the surgery, and we restore them to what the best they can be. That process is as well not instantaneous. It doesn't happen over the night. It takes time, it takes effort. That is why physical therapy is important, and physical therapy is important for our surgery more than any other surgery for the same reason. We don't destroy the muscle that the physical therapy works with.
You want to share with the rest of the world of what your last TikTok kind of was about? Because we've all taken really good interest in that. And we liked your example that you showed. Well, I mean, it might have been a mere bathroom mirror TikTok, but it had really valuable information if you want to share that.
Now, one of the things that we hear a lot before the surgery from our patient is that, doctor, I'm physically active, I go to gym, I don't want to do physical therapy. It's a waste of time for me. And the fact is, and that there are good studies out there, contrary to women, people think women love to watch themselves in the mirror. Guess what? Men love to watch themselves in the mirror even more, but they don't look at their face, they look at their body. Men love to watch at the other man's body and admire their muscles and so on. They love to watch their own body, the muscles and so on. And for that reason, when we go to gym, most of the things we do, we concentrate on the things you see in the mirror.
Mhm.
You do not concentrate. Now, the good news is in lots of gym, they have multiple mirrors that you can see your back of yourself as well. But I guarantee you, no matter what, you will not see your paraspinal muscle. You will not see your iliopsoas. You will not see your multifidus muscle that really matters for your core body. It's good because then you see your latissimus dorsi, your trapezius, and so on. And that's still better than nothing. So that back mirror, look at them as well. But going to gym doesn't replace physical therapy. As a matter of fact, if it would, people with physical therapy didn't have to go to school for 4 to 6 years to be physical therapist. Okay? So, and that is the fallacy of many of our patients, that they think if they're active, it is enough. As a matter of fact, sometimes it backfires because the arms and the legs are ready to do activities that the core spine muscle are not. This balance actually is what's causing them the problem.
Right.
And to go kind of off of that, in the same fact that you had said, as patients, they say, I've tried physical therapy, or I did it for 1 session, 2 sessions. Oh, and it hurt so bad. Well, I tried to explain that same reason that you just said. they're targeting muscles that you are not targeting every day
Yeah.
on a daily living. You're going to feel sore. If you don't kind of feel sore, I'd be a little more questionable on how hard you worked.
And
That's a hard concept to grasp as well.
Right.
along the same path is you don't go to gym and come back and have six packs,
Mhm.
right? So expecting to go to physical therapy after 2 visits and see instant result is the same going to the gym one time after 5 years and coming back and wow, look at my six packs. Now
How I feel when I eat a salad.
That's how I feel when I do like 2 squats. I'm like, oh my gosh.
I go, I ate a salad today.
Yeah.
Feeling frail.
Right.
So, and I think when was we, Amanda, we as well talked about that the women's are actually much better there because you guys do a lots of activities like yoga, Pilates, and other activity that for lots of macho men appears like a too feminine, but they're actually good for you. They're good for everybody. They involve your core body muscle and paraspinal muscle. Okay. So we are going through our expectation management. I ask you to bring it so we can go through some other aspect of what patients should expect and should not expect. So, but you are the source of it, Alyssa. You get those questions asked. You patient do complain to you. What else do we need to talk about when we talk about expectation management?
I think the biggest expectation disconnect that I often see is the idea of the post-op nerve root irritation. It's not so much that they aren't aware of it, because I know I discuss it a lot. Oh, this is what you can expect. It's more so the waiting game after we take care of the initial inflammation. Typically, patients that get the post-op nerve irritation, like you kind of said, get the associated leg weakness, or they have the numbing or the symptoms that go down the leg that can take a few months at times, depending on how many levels you get done, which means, Alyssa, my left leg is still weak. I'm still stumbling over it. What is going on? They don't always like time, exercise, movement.
Let's bring the numbers in, okay? Now, the nerve irritation after spine surgery is not limited to what we do. As a matter of fact, if you go and look at the big papers and so on, there is a 1 to 3% risk of nerve damage after spine surgery, even macrodiscectomy, small surgeries. All the results are seen and evaluated after a year. Everybody in all the, and I have read, I can tell you hundreds of papers regarding this. It's my job to know everything about that. Everybody hush early results. Everybody, though, if they do that, they gather the result after a year. Now, I can give you the result or after a year for our patient, which is in our study, in 303 patients, only one patient still had after a year permanent injury to the nerve associated with the surgery itself. That makes it 0.3%. Whereas in the literature, it's reported 1 to 3%. Another handful of patients, they had numbness still on top of the foot, but that wouldn't limit their life. They would say, you know what? I would take it any time of the day. So true neuropraxia associated with all of is 0.3% after a year. That is the paper we published. And that as well include our initial learning curve. Whereas for the open surgery, that's 1 to 3%. Now, initially, we have to push the nerve to the side and we consent the patient for 15% risk of nerve irritation. That's what they should expect. If they cannot expect that, they should not come and get the surgery. This is what it is. But realistically, it's about 12.5% for 5S1 and probably just about 7 to 8% for other levels. Okay, so in realistically, it's actually much less. And for the open surgery, for traditional surgery, when I start doing that, it appeared to me that Olive has more nerve irritation. But then I said, I'm going to look at it systematically, meaning that every next morning I go to the patient, I examine them and so on and so forth. The difference was that our Olive patient is ready to go home, everything is ready, is done, and says, but doctor, what's that numbing on top of my foot? whereas the TLIF, the open traditional surgery patient, is in agonizing pain in bed, has even not gotten out of bed. That numbness on top of the foot is her or his least concern. He just wants to be able to turn from side to side. But if you ask them systematically, they have, in our initial study, they had over 12.5% initial damage risk of nerve irritation, where OLIF had initially 8.8%. So even that was lower in OLIF, but it appears more because that's all what's left. One of the things you will hear a lot from your patient, Alyssa, is that it starts bugging them in the night when they go to sleep. Why? Because there is no more other distraction. That's all what's left. Same way, we take everything away, everything is good except that numbness on top of the foot, that's going to bug you. Whereas if you have 10 out of 10 pain in your back and blood and the heart is coming out of your spine, that numbness on top of the left foot or a little pain on the top of the left foot is least of your concern. Now, you have to dissect that as well in two groups. Now, there are some patients, we do the surgery even with neuromonitoring, with the computer, looking at the nerves. They come out, the nerve is damaged right after the surgery. So most of the time, not fully. 9 out of 10 times, they actually recover within 2 months, gets really good again. And that can get worse for 3 days after the surgery before it starts getting better. Why? Because swelling gets worse for 3-4 days after the surgery. But then you have those patients that right after the surgery, everything is fine. And then 3-4 days later, things get worse. Now, that is a different entity. In our surgery, we poke through a muscle inadvertently, especially in a learning curve. If the surgeon is starting to learn that, we poke into the iliopsoas muscle. Now, we poke in it, and then what happens if somebody poking you, Amanda? You become sore, it becomes painful, it swells up again. So patient wake up, everything is fine, but the next day, they cannot bring their leg up, and an inexperienced person would say, oh, their quad is weak. What did you do to his quad? It's a nerve root injury. But if you examine them carefully, they cannot bring the leg up not because the quad is weak, but because iliopsoas is weak. And you activate those muscles together, then when you go back and you look back, you see that these are patients, you did a multiple level surgeries, you poke through the iliopsoas multiple times, and the next day, as all tissue, iliopsoas is swelling more. The third day is even more. So some of those symptoms, they weren't as bad right after patient woke up, but they get worse and worse and worse in the next few days. That is what we call iliopsoas compartment syndrome. In reality, it's not a compartment syndrome. It is because compartment syndrome is much more severe, but it's the iliopsoas irritation syndrome. In rare cases, iliopsoas compartment syndrome. So that's a huge difference. If they wake up, they had the symptom right away, or if they develop it a few days later, these are huge difference. And guess what? What nerves run in the iliopsoas? In the iliopsoas, it's a trick question.
None.
All of them. All of them.
It's a trick question. So I go, okay, I'm going to be wrong then.
Lumbosacral plexus. Where does lumbosacral plexus run? In the iliopsoas muscle. Okay, so is it surprising to you that when the iliopsoas start swelling, they get symptoms of many of those, even some of them that you didn't do surgery on?
That would make sense.
Okay, so now you know.
No.
Okay, so it is expected. It is nothing out of the ordinary. It has a very good prognosis. Obviously, we help them at that point. How do we help them?
Anti-inflammatories, some
Very
possible.
good. Narcotics are not anti-inflammatory.
Oh my goodness, you can say that again because like we said, what happens in days 3 to 7? So when do we get the calls of, I need more Alex, my pain is through the roof. And then you ask them, what type of pain? Where's the pain? Is it the sharp shooting, numbing, tingling? Yeah, that's it.
Yeah. So what are useful medication there? Ibuprofen is. Now, for a long time, lots of people thought ibuprofen is not good after bone surgery. Nonsense. I think the effect has never been crystallized. So ibuprofen is fine. What's better, few days only, because it has a negative effect on the liver and kidney, Toradol. And you can reduce the inflammation as well with steroid, Medrol dose pack.
Everyone loves their steroids.
Well, it is important, but we don't give it indiscriminately because no medication is without side effect. And you have to be conscious about what other situation. If somebody has a lot of diabetes, uncontrolled diabetes, lots of other issues, you want to be careful there. But we know it, and then if that's not enough, we put them on gabapentin. If that's not, we go up on the gabapentin, and we go up slowly on the gabapentin because it can cause cardiovascular dysregulation and so on. And if all of that is not enough, we put steroid in the epidural space, then we put steroid and the numbing medication next to the nerve root, epidural steroid injection, foraminal nerve root injection, and so on. And then I can tell very confidently that after a month or two, sometimes 3, even if they have it, most of the time it goes away. So it is a common thing. It used to appear to me very common thing. But when I looked at that, it is literally maximum in the learning curve 15%, and after that much less. But why do we hear about it all the time?
It's
Because
so
there aren't
shocking.
left.
No, because those people who don't have it, they don't call you.
That's
Like
true.
it's like this is like a Google reviews, you know? All those happy people, they don't go and put a review for you. Only those angry and nastier they are, more they put a feedback, meaning that you hear from the same patient who has the worst kind of nerve irritation 20 times, and it seems to you that, oh my God, everybody has that problem. In reality, if you systematically look at that, the numbers are established. Okay?
I say I'd agree with that.
Okay. What else do we need to talk about in that brochure, nice brochure you guys got?
Let's see.
I have something.
Yeah, go for it.
Yeah.
So a lot of times when I talk about spine fusions to people, I'm told don't get a spine fusion because you're going to lose stability. Actually, my uncle worked for Medtronic, and when I was trying to get my grandpa in here because he was having a lot of back pain, my uncle was like, "No, never go get a spinal fusion. You're never gonna be able to move again."
Oh, the mobility
Yeah, talk to
question.
me about
the
losing-
range of motion
Yeah.
question.
Mobility
Okay.
after your fusion.
Very good question. Very good question. Number one, nobody ever should get any surgery if they don't absolutely have to. It has nothing to do with fusion, meaning fusion or non-fusion. Once every other path has been satisfied, exhausted, then surgery would become even an option. But once the surgery is an option, if your choices are you cannot walk and you're going to decondition and die, literally, if you cannot walk, a body made for walking. You remember we had a patient in the surgery center that couldn't walk and deconditioned. He couldn't go even from one chair to another. He's a strong man. He couldn't go from chair to another because if you quit walking, you will decondition rapidly. Once you are in that situation that nothing else can keep you mobile on your feet walking and your pain is uncontrolled, then surgery is an option. In that situation, that what happens in the future, it is like, you're bleeding. I cannot stop your bleeding. Because if I stop the bleeding, you may bleed somewhere else next month. Or if I tell you, I cannot fix your flat tire because look at all your tires are bad. And if I fix it, you may have another flat tire next month. You see, that line of thinking is ridiculous by itself. It doesn't hold up on itself. And I have been saying that all along. For an argument to disqualify an argument in any walk of life, look into the argument if it's consistent in itself. What is the alternative? If the alternative is not having the surgery, it is already what you should be doing.
Mhm.
If not having a surgery is an alternative, you always should choose that. But if there is no alternative, you will decondition, your heart and lung will shut down. If then it comes to the idea of, if we do the surgery, are you going to have more spine problem? Now, the reality is that the fusion takes the motion away. But I can tell you, I have done over probably 4,000 spinal fusions. And if a patient come back to me and tell me my only complaint is that I cannot move my back the way I used to do it before the surgery, that's my only complaint. If anybody comes to me, it would be the first one. Why? Because by the time they need the surgery, that is by that time they come to the surgery, that segment has no motion whatsoever. As a matter of fact, it causes them pain and even reduces the motion of the other segment. As a matter of fact, I hear all the time, I can walk better, I'm more straight, and I'm less pain. I can move a lot better, even though I officially use the back. Now, having said that, they tell me, I have heard, if you fix one level, the other level will go bad, and so on and so forth. Well, let me tell you, there are three reasons a disc is like a tire of a car, and there is three reasons a tire goes bad. It's a bad factory. It's not a Michelin tire. It's a no-name tire built in somewhere. Or how many miles you have on that tire. Even a good tire, if you drive it long enough, will have wear and tear. Even Michelin tire, after 150,000 miles, will wear and tear on you. But then, are you driving that tire on hard road, on sharp stones, on the construction zone when there are 20 screws in every square meter or square foot of that area? Are you driving it to your spine? Your genetic, your age, and how you use your spine, and how you use your spine. If you're an Olympic athlete, if you're a high athlete, you're going to grind your facet and disc and all your joints in no time. By the time a high athlete is in their 30s, their joint look like they're in 50s. If they continue, by the time they are in 40s, the joint look like they're in 70s. Now, if you overuse it, it's going to wear and tear faster. We talked about that as well recently. But is the reason that you have additional spine problem, is it because I'm fixing one of them? For the open surgery, there might be yes, because when we do an open traditional surgery, we destabilize the spine in many segments, and as a matter of fact, we injure the joint to the next segment up. In the MIS, we are running a study. I'm pretty confident, though, that those things don't happen, meaning that the rate of adjacent segment is lower. We are running our study. Hopefully, it will be published soon. But I can tell you for sure, the most definitive reason you will have more spine problem after spine surgery is not because we fix one area, but because you are getting older, you have the same genetic, you have the same lifestyle most of the time. So meaning that once you have spine problem, you're 35% more likely to have more spine problem, not because we fix one of your spine, but most likely because the situation is just applicable to you. Your genetics is the same, your joints, your cartilage are not maybe the best, and you're aging, you're not younger, and you're not going to get younger. And in 3 years, you're not going to be younger.
Right.
So, but that was mobility is a good question, it's an extremely good question. And one of the things as well, I asked my patient, what can I do? What can I not do? If you remember, we had the essence of science not long ago. Our body is made for walking. So frequent small walks are good for the patient. Anything excessive is bad. I tell them often, most of it common sense, but as somebody told me recently, common sense is not that common. Like you should not
told you that.
you should not put a 1,500-pound swing set for your grandchild 3 weeks after the surgery. You should not do that. You should not.
Bossy, it's minimally invasive surgery. Shouldn't I be able to do anything right after surgery?
Well, I would say you shouldn't do it before the surgery. I would say you should not do it before the surgery. or after the surgery, or without the surgery. Then I will look at your significant other and I tell him, you should not put this 1,500-pound swing set by yourself 3 weeks after a vacation. Definitely not 3 weeks after a surgery. And that should be on a t-shirt. You should not do those excessive damaging things, not even after a vacation. How do you expect to do it after a surgery?
Right.
Now, there's something they should do. Frequent small walk. Changing the position from sitting to standing. If you are going to go work, have a desk that you can work standing and sitting. Go walk, to small walks. They want to park next to the Walmart, but I tell them park in the back of the Walmart. That 10-minute walk is the thing your body really, really needs now. Okay? What it doesn't need is a 5-mile walk. What it doesn't need is a skiing, going on a ski trip or jet skiing or anything that has high impact. For that, we give you a brace even. But we want you to avoid that. But regular driving, you cannot avoid. We give you a brace. And they ask me, how long should I wear the brace? Well, generally, what do you tell them? If they ask you, how long should they wear the brace?
Again, it depends on the patient, but typically for me, for the first month until you come back to the office to see me, I want you to wear it pretty much anytime you have the ability to fall is my idea. So when you're up and moving, long walks, out of bed, not stationary.
There's a rule of thumb, 4 weeks when you walk, 4 months when you're in a vehicle, vibration, okay?
Yep.
But then after that, you wean yourself off it. You wean yourself slowly off it. They ask me a lot. I'm asked this question almost every time. When can I do this? When can I do that? And so on. I say, do a little of it, then wait 3 days. Sometimes your body tells you next day that is not right thing for you. Then add a little more to it and a little more to it, a little more to it. Go slowly up, but generally don't lift, bend, twist more than 8 pounds for the first 2 weeks, not more than 20 pounds for the first month, not more than 35 pounds for the first 6 months, and not more than 50 pounds ever. Those rules are out there. Nobody should constantly lift more than 50 pounds by themselves. That's an OSHA, not even a bossy or spine thing. That, by the way, that's the reason airliners, they charge you more. That's their excuse to charge you more. If your luggage is more than 50 pounds, they charge you more because they say you have to hire 2 people to carry it.
Okay.
You have to pay for it. It's a scam,
I've never seen 2 people carry 1 bag, but
no, they're not doing that.
but they're still charging you more for that.
I
That's
get the concept.
Yeah. Now, another thing, they ask me, can I ride a bike? What do you say if they say, can I ride a bike?
The same thing that you just said. Give it
What?
a shot slowly and surely. You know, it's a good activity. Riding a bike is
How do you ride a bike? Do you just go straight street or do you go 60 miles the mountain down? How do you see many of those things? We cannot really, they tell me, can I vacuum? Do you have a small little dirt devil or do you have a vacuum? Is that 500 pounds industrial vacuum thing? But I can tell you all of that is depending on how you do that. As long as no bending, twisting, lifting, and we can comply with that, start slow and go up. There's something I can tell you should not be doing in Minnesota after spine surgery. Why?
There's a lot of reasons.
After what, 60, you really shouldn't be shoveling anyway because your risk for heart attack goes up. But that bending over and then twisting with all that snow.
Bending, lifting, twisting. It has all
everything involved in what you're not supposed to do. Yeah.
We don't care about heart attacks.
Heart attacks aside.
Yeah.
If anybody has seen Alyssa in clinic, anytime, it's almost inevitable, at least once a day.
Yourself in third person? Did you just refer to yourself?
I did. I'm reflecting on the fact that when you bring this up, at least once a day, I will have a patient that will casually drop everything in their hands. And then they go to bend over and I go, don't you dare. You are not allowed to bend over and pick anything up while you're in the sights of me. They just chuckle and I'm like,
Like, no,
But
I'm
they can
serious.
do it the correct way. Like, see, I can bring my leg up, put it on a stool, and then tie my shoes. I can put my foot on the knee and tie my shoes, or I can bend tie my shoes. So we send them to physical therapy, to occupational therapy, exactly to learn that. Like after the next surgery, don't eat a big steak, eat softer food.
mashed potatoes.
Yeah, exactly. And then when you're in the car, they ask me, "Can I drive a car?" My generally say, if you can make a good use of your right leg, sometimes that's a problem. If that's not a problem, you can use it, and you are not on narcotic, you can. For the neck, though, I don't want you to do this because I want you to learn how to turn your whole body to look over your shoulder. You still have to look over your shoulder, but you have to learn it to do it the right way, and you have to plan it. You cannot just drive like a bossy, miss the exit 5 times, and then do the GPS and move your neck like this, and then still miss the
man.
thing. Yeah, that bad. Amanda knows all about that. So you have to plan it. Same with the drive. Like they ask me about um, all the activities that I have no idea how they do that. Like the bicycle is one of them. Can I go to gym? My God, what do you do in gym? When you go to gym, what do you do? These are I laughingly tell them, for me to answer that, I have to come and live with you for a week and see how you are doing it. But I can tell you, if you don't do bending, twisting, lifting, do it a little, watch yourself for a day or two, because it may tell you next day it's not good for you, and then add to it more and more. There is something they always hesitate to ask.
Sexual activity.
Yeah, and Amanda, you're right on.
It's on.
Very rarely they ask that. And you get some of them to the ER, you look at them, you know what's going on, that they have been over exercising their spine. And especially worst thing is about the good thing about sex is it gives you oxytocin. It gives you things that suppresses the pain. It's supposed to do that. But then you forget, you suppresses the pain, and then the act is done. And now all of a sudden, see, oh wow, this was not maybe the right thing.
The next
So-
day.
Not even next day, next hour. And then they end up in the ER and so on. And so, what do we tell them, Alyssa, regarding sexual activity after spine surgery?
It's very similar to other activities that I do. You know, if they can make it a month, that's for me, if I can make it 4 weeks without doing too strenuous activity, that's good for me.
No, don't be cruel. For
I
some people, it's
I,
important.
as a provider, give them, I say, here's the timeline answer. This is, you know, there's always a doctor answer on if you want to follow everything by the book, here's the Bible. And then there's a realistic answer where, you know,
Let's
people-
write the new Bible then. If that's a Bible, let's write the new Bible.
Right.
The new Bible of sexual activity after spine surgery. The new Bible is, it depends on how you do it.
Yeah, your Bible says to do it laying on your back. That's the safest. And it can be resumed 4 to 6 weeks after surgery. That's what's in your Bible, but I can always make edits.
Well, you see, our
Bible's
Bible is not a true Bible. We can't change it.
Yeah,
Our Bible is not a true Bible. We can't change it. What the new Bible is it's all depending on how you do that. The rule of thumb is if you sweat doing anything, you shouldn't be doing it for the first 4 weeks after the surgery. No activity should make you sweat or break in sweat or make it hard for you to breathe, make you short of breath 4 weeks after the surgery. You can do all those exercises later. Now, what are the situations that if that is so important to you, what are the situations that you can engage in a sexual activity without making you sweat? You have to be the
Your back.
passive partner. You have to be the passive, not necessarily on the back, but you have to be the passive partner. You have to be in a situation that you are in control, and you have to be able to say time out. You have to add that consciously to your, but not only sexual activity, every routine.
Mhm.
Do not start things like, don't start climbing the ladder and halfway you decide, no, that's too much for me. You have to talk to your partner. You have to discuss it. You have to understand that you have to take it slowly, and you have to be passive in that endeavor. Realistically, the first 2 weeks, I don't believe most of patients feel like they want to have surgery. After regular spine surgery, for months, they don't feel like that. But you would be surprised now. The way we do the surgery, they feel ready for it within days, which I take as a badge of pride. I bring them in days where they would be after a month or two. They're
Mhm.
ready for sexual activities, but they just have to be careful, because the reason they feel good is because we caused less damage and we put screws in that hold them together. It is not because the healing is advanced.
Mm.
They don't feel good enough for this because healing is advanced enough for excessive activity. It's because, and if they do that, they're going to loosen the screws and so on and so forth. That will cause a lot of damage. So we can generally keep it there as a general thing, but when we see the patient, you see, the problem is if we tell them you can go and have a sex or sexual activity after 4 days, if you do this and this and this and this and this and this, they're just going to stop reading it. You can go and have sexual activity after 4 days, and they start doing Kama Sutra, and then you have to deal with the consequences.
Right.
Okay, so, but generally, I tell my patient, as we discussed, if you're in control, if you understand, if you are a good partner, you can tune with each other. And if you're more passive partner and you don't sweat and you don't become short of breath during that process, you can assume it sooner.
Okay.
What did we not discuss regarding patient expectation?
Well, we could probably go on for about 7 more hours minimum, but I mean, I think that's pretty good.
We did cover pretty much everything that's on this list. We only brushed over having additional surgeries afterward.
Yeah, a little bit. We talked about
Barely-
adjacent disease.
Yeah,
and
Jason. Yeah.
take care of one place and it opens up the can of worms for the
Okay,
other.
well, let's
Sure.
put it this way. I used to make fun of my father and telling him how old he is. He used to tell me if I'm lucky, I get his age. Because if all of us, if we are lucky, we get old. Because if we are not lucky, we die young. And there's only these two alternatives I'm aware of: dying young or getting old. Or are you aware of any other alternatives?
No.
So what does that mean? I'm telling them, I'm hoping one day they would be 120 years old. By that time, they will need me for every single vertebrae they got. Okay? So it is not a matter of they're going to return to us. I'm hoping they get old enough for them to need us again. And that is something that we have to come with peace with. Especially the word midlife crisis is actually made for men, but now as well women. They are getting to the age they understand the mortality of their body, and they cannot psychologically deal with that.
Mm.
There is a reason so many big actors, celebrities, they commit suicide in their 50s, early 50s, late 40s, early 50s. They come not to the grasp with the fact that this is not the cute body they had many, many years ago, and it cannot do things it could do many, many years ago. Now, Alyssa, you and I, we are going to be on receiving part of the frustration, of the anger, of the madness that comes with that, with people realizing they're not young anymore. Right?
Yep.
And we help them, again, go read the natural history of spine, find alternatives, find other things that are fun. In the same day, I had that patient who was angry with me. I had another patient. Everything was on the lower side. It was bad. Patient had nerve irritation. Patient did not recover completely. Patient could not walk as good as the other patient. But that patient was the most satisfied. They said, the sharp pain that I had is gone. That's all I'm caring about. I can walk again, even though I need to use a walker. I can walk. And guess what? He used to do carpentry. Now he would go and find piece of wood on the street, on the walk, small walks, and make cross of it and distribute it in the church every Sunday. And that was he had that hobby. He changed his hobby from carpentry to something that smaller level and would give it to people in the church. He was the happiest person. And I can tell you, my result for the angry guy was 10 times better than the result for this totally satisfied guy, because his expectations were realistic. They were manageable.
Yeah.
Okay. So what else do we need to talk about?
I think we're good.
Alyssa, does this podcast satisfy your need?
This podcast was this podcast was good. Like I said, we could talk for days, and I'm very passionate about patient education. So as you can imagine, I do a lot of this communicating to patients multiple times, and we'll still be doing it, and that's okay. That's what I'm here for.
One of the things is I tell my patient, let's pack it. The medication we distribute is to make them comfortable. It is not for them to go do things that they couldn't do without medication. Imagine I can numb up your hand. You can go pick up a hot iron or a glowing piece of coal. You won't feel that, but your hand will still burn. The medication, like, doctor, please give me more medication because I cannot go on doing the afternoon my golfing and so on.
What does that tell us?
That you shouldn't be doing golfing. Body
yet.
is not ready for that yet. Okay, so the medication we are giving you is to make you comfortable, and we give you multiple medication. Alyssa, I want you to go over the medication that we give to the patient so they understand what is that medication, what it does, and what it's not supposed to do. It's not supposed to numb up all your sensory so you can go do things that cause you damage. Go ahead. What do we give patients regularly?
We send them home on 3 different medications. One is some sort of narcotic or pain management medication. The second one is some sort of muscle relaxer. Typically, we use methocarbamol or Roboxin. And the last one is we typically give them a hydroxyzine, which is kind of an anti-anxiety as well as counteracts some of those side effects from the narcotics, the itching, the uncomfortable feeling. So in combination, they work together to maintain the patient's, like you had said, comfortability to help counteract some of those harsh side or symptoms after surgery.
No, and we tell them for the methocarbamol and hydroxyzine or Vistarol, we ask them to take for the first 2 weeks around the clock.
Scheduled.
They're safe. They are good. The narcotic is what they put you they're in danger and is troublesome. That only you take as needed. And sometimes we add additional medication like Neurontin or Toradol and so on. But coming back to that, the medication is not to numb up your nerve to a point that painful things can be done. It doesn't make it safe. A pain medication is like resetting the smoke alarm. And the pain is the noise of a smoke alarm. Let me repeat. The pain is the noise of the smoke alarm, and the pain medication, resetting it, that smoke alarm button. Your house will still burn down. Okay? And just imagine, the fire department would just come and they just would push the smoke alarm button instead of putting the fire out.
Right.
That is what you should be expecting. Now, having said that, we get those midlife crisis men and women. They want to go do marathon. They want to go do this and that. And they ask for us to restore that or give them pain medication so they can go and do that?
Mhm.
And our answer to that is that this is just unnatural. And as physician, we cannot do unnatural things.
Exactly.
And I think that's a good place. to
Yeah,
end that
I think
there.
this is a perfect place to end.
So-
Thank you guys for watching. This was Essence of Medicine. So we talked about post-op expectations. I'm Amanda Armagost.
I'm Melissa Hopper.
And I'm Dr. Abbasi for Essence.
Thanks, guys.
Thanks, guys. If you have questions, leave them in the comments.